So it's a great pleasure to be here today to launch the certification of stroke centers in Latin America, and together with World Stroke Organization through the roadmap and Ibero-American Stroke Society. The certification of stroke centers is critical to ensure that hospitals implement and monitor all priority evidence-based strategies that change the natural history of stroke, reducing mortality and disability. It's a great opportunity for continuous improvement of services and qualification of comprehensive assistance in the region, with the commitment of stroke centers to organize and train the entire local network. So it's a great pleasure to be here with our friends from World Stroke Organization, Ibero-American Stroke Organization, and all international neurology and stroke societies from Latin America, from 10 countries, together also with our friends of MT 2020 initiative to discuss about this and to present the criteria for certification. I'd like to thank to Professor Werner Hacke that will be lead this initiative in Latin American with me, and Professor Carlos Cantu, from that will be the next president of Ibero-American Stroke Society since next week. So I'd like to introduce Professor Werner Hacke, that is past president of World Stroke Organization and one of the most important stroke leaders, main author of several important papers in stroke, that is here today with us from Germany, University of Heidelberg, to talk about the importance of strokes, the certification of stroke centers, what is important to implement. Professor Hacke, please.
Thank you very much, Sheila. I'm now trying to show my screen. Just give me an okay when you see it.
Yeah, it's perfect.
Oh, wonderful.
Perfect.
So thank you very much for having me included into this inaugural meeting. And you asked me to talk about the importance of stroke unit certification for the implementation of evidence-based treatment in acute ischemic stroke. And I must say, without acute stroke units in a country that are certified according to similar criteria, there would not have been the progress that we have made worldwide in the field of acute ischemic stroke. All treatments that we now have available are based on the fundament of acute stroke units, and everything else is surrounding them. Here is my current disclosure slide. And I would like to talk today about stroke unit care, intravenous thrombolysis, mechanical thrombectomy, and decompressive surgery as the evidence-based treatment options in stroke. Of course, I will not go into any details about it. I made my point already. Intravenous thrombolysis, mechanical thrombectomy, and decompressive surgery, among other approaches, would not be available without stroke unit care. Stroke unit care has been the first successful stroke treatment, and it features the interdisciplinary team of people working for stroke patients, and all the acute stroke units around the world provide all the modern treatment options. And as you all know, stroke units are useful for all types of stroke, independent of age. We all remember that the first stroke units were rehabilitation type of stroke units, and even they were successful in reducing dependency and mortality. Today, we will be talking more about the acute and hyperacute stroke units and stroke centers. And as you all know, and you are more aware of that than I am, in many countries, stroke centers are rare, regional stroke units are rare, and the best many regions can afford are local stroke units. But even those, the local stroke units, or what we call stroke-ready hospitals, that have a stroke unit and can provide thrombolysis, are essential. And reaching that level is something very important for many healthcare systems around the world. Actually, in many of the low and middle income countries, we see large gaps in stroke services. By far not enough stroke-ready hospitals, which means CT scanning and TPA, but in some metropolitan areas, even high-level interventional sites. But the majority of the population does not receive a standard acute stroke care. You will hear more about the WSO roadmap by Professor Patrice Lindsay, and I'm just showing the two slides here. First of all, we looked at advanced, essential, and minimal care services, and we have to admit still worldwide, minimum and below minimum is representing 70% of the population. And only 20% are essential services, that is a typo here, and 10% maximum is advanced. So the minimum health care services, they are not always stroke-ready hospitals. Very limited access to diagnostics, very limited access to physicians or other healthcare providers, and care provided in local communities without coordination. And when we talk about the essential services, this is something that for most countries would already be a major step forward if that could be rolled out nationwide. Stroke treatment delivery requires a chain of organized services, and failure to deliver one of those services will jeopardize the entire stroke service and the management procedures. And this is why a certification progress that will review the availability of the essential services and, if missing, will withhold certification until the missing link is established is so essential. What do we need in the acute stroke treatment scenario? Well, we need preclinical services ranging from education, EMS services, and established referral systems. We need the stroke unit care with the optimal treatment on the different levels of care. And this is guaranteed by written SOPs and continuous education. And then finally, we will have the chance to provide IV thrombolysis and mechanical thrombectomy. But it's not over with that. Rehabilitation services, ambulatory and in hospital rehabilitation systems are essential. And if we fail to install secondary prevention, well, then we have done something good for the acute stroke, but something less good in preventing the next stroke to come. These requirements that I just mentioned are only available in the setting of certified stroke units. And the certification must follow the same requirements in a country and, if possible, in a region. And also the nomenclature should be the same. We should exactly know what we mean by a stroke center, by a comprehensive stroke unit, by a regional stroke unit, by a local stroke unit. And therefore, I believe the approach of generating a continent-wide certification tool for South America is ambitious, but I hope that it will be a tremendous success. any type of certification is helpful for the implementation of proven therapies on a national level. Who should do the certification? I know this is a political dangerous area, but from my experience, and I've been in the field of stroke unit certification for almost 20 years now, 25 or actually, I strongly support a peer-reviewed type of certification. That means the rules and the key numbers must be set by stroke neurologists or stroke physicians, not by profit-oriented entities, even if they are linked with societies. We need the help and the support by administrators, payers, and politics. In a second or third phase, we need site visits by specialists using uniform checklists and really looking at whether what has been reported on paper is existing in reality. Failure to meet 90 or 85% of the requirements for a certain level must lead to detailed discussions with hospital administrations. And I can tell you from my experience, whenever we came somewhere and said, you don't have enough stroke nurses to get a certification for 8 stroke unit beds, and we talked to the administration, within a few hours, the additional positions were created. And when they said, oh, we only have the CT scanner available during working hours, we told them, then you will not be a certified stroke unit. And within a few days, they had changed their availability program for CT scanning. There must be some fees for this. And those fees cover for the amount of work that is put into the certification process. But the fees should not be prohibitive. They should be oriented according to what the local or national health service is prepared to pay for a certification. And there is one very important thing, and that needs a lot of political lobbying. But having a certification as a stroke unit should lead to better reimbursement for stroke patients compared with the reimbursement hospitals get that do not go the difficult way towards certified stroke units. We started our stroke unit certification 25 years ago in Germany. And it was a German Neurological Society at that time and the health ministers of a few states that came up with the idea of planning statewide stroke unit systems. And they asked the stroke neurologist to define the requirements. They approved the program and asked the stroke physicians to execute the certification process. And we came up with the 3-level stroke centers, regional stroke units, and lower stroke units. And there was some additional thing that was already established 20 years ago. We said the lower level units must have an established cooperation agreement with higher level centers, which eventually led to the telemedicine networks. The certification documents were reviewed by the Stroke Unit Commission of the German Neurological Societies. The site visits were performed by peers and administrative specialists. And the fee for the certification was quite low, under 2,000 euro per center in a high-income country. And in 2005, we already had 100 certified stroke units. In 2010, the program was rolled out nationwide, and the German Stroke Society became responsible for the certification, together with a commercial provider. And most importantly, the stroke unit certification requirements were adopted by the national DRG reimbursement system with a procedure called stroke unit treatment, and that grants a much higher remuneration for stroke patients treated on stroke units, even if they are not thrombolized or receive mechanical thrombectomy. Today, in our country of 80+ million, we have 327 certified stroke units. You see one map here with red and blue dots. The red dots are the stroke units and the blue dots are stroke units which are in a telemedicine program. And on the right side, everything that is in green means patients from this region reach a stroke units in under 30 minutes driving by car. And only the red ones, these are the areas not densely populated where they need 50, 60 minutes to reach the nearest stroke unit. And with this system, we now have almost 80% of all ischemic stroke patients treated on a stroke unit. 12 additional percent are treated on ICU units. 18% is a nationwide rate of TPA, and we just passed, during the Corona pandemic, the 8% mechanical thrombectomy rate. But this took 25 years of constant work and lobbying. So let me summarize. You guys have a great chance to create something big because stroke units are the center of stroke care. And that is not only true for ischemic stroke. The certification guarantees availability of high-trained personnel and the availability of minimum technical requirements. Written SOPs and constant training establish high treatment standards, and the stroke unit certification is essential for successful stroke management systems. And with that, I wish you good luck. This is a great endeavor, and I'm sure you have the people to guarantee success. Thank you.
Wonderful, Werner. Thank you. Werner Hack was a very important person in the development of stroke care in Brazil, giving us advice since the first step. So Werner, wonderful lecture, and I'm sure that your advice now will help us a lot to develop this challenging program, but I'm sure that you'll be successful. So now I'd like to introduce Patty Lindsay. Patty will talk about the WSO's roadmap, how to use it, and the main elements of essential and advanced stroke centers. Patty developed the roadmap in World Stroke Organization. She is nurse from Heart and Stroke Foundation in Canada, and she has large experience in certification of stroke centers, Canadian stroke certification. So Patty, thank you for joining us.
Great. Can you see my screen okay, Shiva?
Yes.
Great. Obrigado, and welcome. Thank you everybody for having us. Greetings from Canada and from the Heart and Stroke Foundation of Canada. I've been a member of the World Stroke Board for 8 years now and have been actively involved in their guideline development as well as the roadmap. Within Canada, we also have a stroke certification program, and I'm one of the people who developed that program as well as a surveyor. So I'm going to add in a little bit of my experience as we go. I have no declarations or conflicts of interest relative to this talk. So today what I'm hoping to do is introduce you to a little bit of the background of the roadmap, how it is structured and how best you'll be able to use it, as well as highlighting a few elements to pay particular importance or attention to. And Werner gave a great introduction to this talk. You know, talking about the stroke units, they're a very important part of the roadmap, and I will not repeat that data, but glad to have that as the launching point for this for sure. So why did we create this roadmap in the first place? Well, it was intended to be an implementation resource. In 2014, we created the World Stroke Guidelines, which was a summary of the key elements of stroke care, looking at all the other guidelines in the world. And there's over 130 different stroke guidelines published around the world and in different languages. So we looked at many of those that were high quality guidelines and came together and found the common elements among them. Developing the guideline itself was only the first step. The importance now is to help people understand how to implement those guidelines and how to bring them to life within their own centers. And that was the goal of the roadmap. It also was a way to bring some consistency and standardization to stroke care around the world. So as I mentioned, the first guideline was published in 2014 and currently will be undergoing an update with a new guideline committee at World Stroke over the next year or two. From the guideline, we developed the roadmap. The roadmap was broken down into 3 main components to help people as they implement stroke care. The first was understanding capacity. As Werner pointed out, over 70% of areas only have minimal access to services. So what is the capacity within your region to develop stroke care? And not just what is there today, but what is the opportunity to grow that and to build that. So just don't look at the now, but look at what is that potential and what is the timeline. Werner gave us a very long timeline where he's worked extremely hard in Germany and all of Europe to increase stroke services. So y'all have to start somewhere, and that's what the capacity component is for. The second component...
Patty, sorry, I think it's better you put in presentation mode to put in the full screen, I think.
It's in presentation mode, Sheila.
Oh yeah, okay,
Yeah.
We can see the okay, no problem.
Yeah, just you have to click on display settings on top, and then...
Because I'm in full presentation mode, that's all I see.
Yeah, okay, yeah.
Okay, no problem.
Yeah,
You can see very well. Thank you.
Okay, sorry. The second component is practice, which we've talked about are the guidelines. So what are those individual things you should be doing to treat a patient from the time they're recognized with having a stroke, so from symptom onset right through to presentation at a medical facility, recognition, investigation, treatment, and then also including the long-term recovery. The third part is quality. I know Sheila has done tremendous work at collecting data across Brazil and within other parts of South America to understand the current situation with stroke care. So within the roadmap, we've put all these 3 pieces together to help you really understand a comprehensive way to build your stroke programs. So within the roadmap, we want you to think about 4 major questions. One is, what structures are needed to deliver stroke care? And those structures include things like the physical services, the human resources, which is a very important component, the equipment, and the funding. The second question is, what should be done? Well, that's where we talk about the guidelines, which should outline the many elements of treating stroke. Other important pieces there are implementation tools, pocket cards, algorithms, all of those things that help you at the point of care. And now with technology, there's so many more apps and different things to help you in real time. The third part is how well is it being done, which is the collecting the data and the quality. But once you have all that, you don't stop there. It's really important to assess that data and to look at it very often and to identify areas where you can still improve and continue to push your systems, as Werner demonstrated that they've done and had huge success in Europe and in Germany specifically, to continually improve care and to increase better outcomes for patients. In Canada, we spent 10 years building the Canadian stroke strategy. So much like where you are now, is building those systems that have high quality centers that would meet stroke certification. And at the end of our 10-year period, we stopped and looked at those regions who are early adopters, who are able to more rapidly put the services in place and coordinate care, and compared those to the provinces and regions who are very slow at it. And today there's a couple who still aren't quite there. What we found is a very significant improvement in mortality, decreased mortality in the early adopters. So as you see on the tails of the slide, those decreases or after the strategies were put in place by the early adopters compared to those who did not have systems in place. So this is real data to show you that, it's great for us to say, get certified, build your system, but we actually have concrete data to show that it actually works and improves outcomes. The important thing as you're thinking about your certification, it's not all about giving thrombolysis and getting access to endovascular therapy. Those are critical components and our best treatments with the highest evidence. But patients go through an entire continuum and an entire journey when they've experienced stroke, from awareness through to prevention, as well as acute services, that rehab, recovery, and end of life. It's important as you're building your service, and within our roadmap, we've taken into account this full continuum. We've developed a framework within the roadmap that does, as you see, outlines each stage of the continuum in those oval bars at the bottom, the colored bars, and defines what kind of services you should be considering at each stage. As Werner's already showed you, we do consider services and what should be done at each level. We recognize that not people who are providing service within a minimal set of resources are not going to be able to provide all of the highly advanced stroke care available. And we recognize that. They may not be the best areas for certification. Certainly, essential and advanced groups should be. That being said, every group should be looking at the roadmap to see where they should be and what the potential is. And as demonstrated by Germany and other countries as well as Canada, doing it in a stepwise fashion rather than thinking it's all or nothing. It's a slow, gradual, stepwise process. So working towards that. So now let's look at a few components of the roadmap in a little more detail. The first part, as I had said, was assessing your capacity. And it's not just how many staff do you have, it's who are the people you're serving. Do you understand the kind of people in terms of age, in terms of other demographics such as gender mix, the types of strokes seen more often, the higher prevalence of certain risk factors? Do you understand that population? And are your services being designed to meet the needs of that particular population? Looking at what you have now, what your resources are, human resources, what kind of training do they have? What kind of capacity might you need? What gaps are there to fill? So that's the first step, is really understanding what you're capable of doing now and what your potential is, incrementally increasing over time. So as you've seen already, we do have a list of what all the things you need to consider as capacity pieces or resources in order to deliver the stroke services defined in the recommendations and the guidelines. So going through the roadmap, you should be using it as your self-assessment to determine what you have and don't. And that will help you understand what category you fit. Next is to really think about implementation of the recommendations or the guidelines. That's the evidence-based care, such as access to thrombolysis, getting a CT scan and a CTA early on in the process. There are many guidelines. The World Stroke ones, as I've said, are a summary of what's in many of the best world guidelines, such as European Stroke Organization, Australian Stroke, some of the ones from Latin America, the Canadian Stroke Guidelines, the American Stroke. So and the UK ones, we brought those all together and did a synthesis to help you to understand what those key elements are, because all of our guidelines have a lot of similar data, which is what we've summarized, as well as some country unique pieces. So taking those guidelines, looking at them, understanding them within the context of your country, the way services are developed and available is your first step. Like with the capacity piece, you should be going through the recommendations themselves, which is that second part, and understanding, can we deliver the service? Do we currently deliver it? If not, what do we have to do to deliver? And we've identified what the expectation is on whether each of these guideline recommendations, what level they should be delivered, whether it's all three or essential and advanced or just advanced, such as EBT, which would fall only in the advanced category. So again, part of your preparation for your stroke certification is to understand what's in place, look at the parts you can't check off, and start a plan to implement those particular pieces. The third part, as I indicated earlier, was measuring. Is as you're building your system and working towards certification, part of the certification is demonstrating through data how well you've been delivering service and the quality of care, because it's not enough to just have those services. If they're not resulting in improved outcomes, better quality of life, lower complications, lower mortality, then maybe that program's not functioning as best it can. And that needs to be assessed through, validated data rather than just observation. So where do you go from here? We've given you an overview of the roadmap. So our recommendation now is that you should pull your team together to look at the sections of the roadmap and have a process to walk through each of them to complete your self-assessment, identify your gaps, and start a plan on how you're going to fill those gaps to work towards being eligible for certification. And not just being eligible, but ensuring that you actually pass, because that's your goal, to deliver the best care you can. And we know that there's tremendous dedication and desire to give the best care possible. And oftentimes it's not your will and desire that's the problem, but the circumstances of your environment and the resources available to you. And we understand that. So how do you find the balance in between to compensate where you can? A very important piece of this that launches all of this is awareness. So with World Stroke Day just a few days away, and our Don't Be the One campaign, promoting the signs of stroke, promoting what people can do to prevent both the first stroke and recurrent stroke are critical pieces that should be part of your plan. Not just treatment once they show up at your doorstep, but planning in advance and focusing on prevention. Another key piece is education. Education for all of your staff members, no matter what part of the continuum and what their role in stroke care is. The World Stroke Academy has got in-depth education on many topics, all of which are relevant to delivering the care defined in the roadmap. And we strongly encourage you to take advantage of leading experts around the world presenting this information. Finally, supporting people with stroke is critical. Educating your staff is important, but educating your patients on what happened and how they can become autonomous in self-management, both the patient and the family, because we know that most of the care after hospital falls to the family to support the person because there's just not enough community services to treat all strokes that have happened. So educating patients, these are examples of some of the many education tools we have at Heart and Stroke Canada. They're freely available on our website. Within the Heart and Stroke the WSO website, there's also an area on our website for stroke support organizations where we have a list of resources from around the world, and we encourage you to take advantage of those. All of this work cannot be done by one person alone or a few. There was a huge team involved in all of the work developing the guidelines and the roadmap, and I wish to acknowledge them all today, including, my close companion on much of this work, Bo Norving, who you'll hear from next. So Bo and Werner, thank you very much, and Sheila, for all the work that you've done to support getting to this place with the roadmap. And we wish you all in South America and Latin America well in your pursuit. We're all here to support you and happy for you to call on us at any time. Obrigado and gracias.
Thank you, Patty. Perfect, wonderful. So you use the roadmap to classify our hospitals and to certify them according to the roadmap. So it's a wonderful job. Thank you very much for this. And now I would like to introduce Professor Bo Norving from Lund University, Sweden. Bo Norving is past president of World Stroke Organization, with a large experience in organization of stroke centers and stroke systems of care. He has a very important job working with the World Health Organization to put the stroke on agenda, in the world agenda. And Bo will talk now for us about the European Stroke Action Plan as a model for organization of stroke systems of care. Bo, please.
Sheila, thank you very, very much. Thank you for inviting me to this meeting here. And I think it's just so wonderful that this is now under discussion. And I see this as different regional initiatives. There is a global plan from the World Stroke Organization, and there are many regional initiatives. And I think this is one of the most important things that is currently in place. I do not see this as isolated regional initiatives. I see these as parts of a global network to develop the services. And if there is one key word in everything here that we are sharing common, this is absolutely the development of the stroke units. This is key. This is so extremely important. So I will speak to you now about the European Stroke Action Plan. As you heard, I've been very much involved with the World Stroke Organization for very many years, but also much involved with the European Stroke Organization. And like Werner and myself, we were there from the very beginning when the European Stroke Organization started, and we're happy to see the development of the ESO. So there is background here. First of all, these are my disclosures. A background in Europe that I think Europe created the very first stroke declaration on management of stroke in a region. This was a Helsingborg Declaration from 1995, and the initiative was originally from one person. It was Kjell Asplund, who was the chair of the European Stroke Council at that time, who came up with the idea that there should be a European conference setting strategies, and this was done together with the WHO Regional Office for Europe and the European Stroke Council in cooperation with some other societies. This was back in 1995, and the layout of the declaration was first to lay out essential principles for good practice. What do we know? What is the background? What is the evidence? Then to set the targets for 10 years ahead, and third, to identify research priorities. And each of these were for 5 domains, for 5 different areas. First, the organization of stroke services. Second, management of acute stroke. Third, secondary prevention. Fourth, rehabilitation. And fifth, and I think this is important, that this was already 25 years ago, evaluation of stroke outcome and quality assessment. This should be an integral part of the stroke services, that you also monitor the quality of the services and that you have measurements. I was there in 1995, and if I go back and look at the declaration, what were the principles? What was the knowledge at that time? This was before the area of acute therapies. This was before thrombolytic therapy was established in Europe. There was one thing that is common today, and that is stroke unit. This was the main emphasis 25 years ago, and is still the main emphasis. But you become very humble when you read what the situation was 25 years ago. There were texts on lumbar puncture. There were very many segments of the declaration that is totally out of fashion, and it's very fascinating to go back and see what were the recommendations at that time. So 10 years, or actually 11 years later, it was a second Helsingborg Declaration. And this was now phrased European Stroke Strategies. I was one of the organizers of this. And again, it was a very similar principle as the first conference, with essential principle of good practices, setting targets, setting research priorities, and the same 5 domains that there was on the initial Helsingborg Declaration. So what could we say at that time? Well, many things have changed over 10 years. Then was the period that thrombolytic therapy has arrived. This was one of the main topics, to get patients to have access to acute therapies with thrombolytic therapy. But we didn't have very good measures from most European countries on what is the status. Have we reached the targets or not? It was very difficult to say. It was very clear that there were very many countries who did not have the targets met at all. And there were some statements, or even say testimonies at this conference from countries in the eastern part of Europe who stepped up and say, we don't follow these rules at all. We use drugs that are not recommended. We spend our finances to do things that are not recommended, and we want to be part of this and to develop this. So what was the impact of the Helsingborg Declaration? Well, it was used for many years as a reference document for building up stroke services. If there were in one country ministries of health or strokes action that wanted guidance on what to do, this was a resource document to say this was the official document to refer to, but there was no clear, strong implementation plan of the second Helsingborg Declaration. So this came up again a few years ago, the need for a new Helsingborg Declaration. Now it was much more clear that implementation of adequate stroke services in Europe in the year 2018 were absolutely unequal and absolutely incomplete. Data show that about half of all patients in Europe didn't have access to stroke unit therapy, did not have access to acute therapies. This is really a shame that so little had been implemented, and also that the resources for stroke do not match the societal impact and the burden of disease. So the decision was taken by the ESO in December 2016 to proceed and develop an extended third Helsingborg Declaration, now in cooperation with the Stroke Alliance for Europe, the SSO, the patient organization for Europe. There were discussions a long time to have WHO in Europe also on board. There were some diplomatic problems to do so, and finally it was decided, no, it's ESO and the patient organization together. It turned out to be impossible with the bureaucracy to get WHO involved, but we felt on the other hand that maybe that is better. They can support the declaration from their part. They doesn't necessarily need to be inside and do it. So this was very, very rapid work, I would say. The decision was taken at the dinner table in December 2016. The next year was hard work, and 2018 in March, it was launched on a meeting in Munich first that was webcasted with the discussions, and then it was presented and launched at the European Stroke Congress 2018, and the publication came a little later the same year. So I got the task to share this work, and I can tell you it's one of my more challenging work that I've been done, because there were so many people involved with this. There were different working groups. There were 7 domains now with the new Helsingborg Declaration or with the European Stroke Action Plan. Added now was primary prevention, and added was life after stroke. We were very careful that it should be absolutely free from industry, no industry involvement overall in this action plan. This was very, very important. So again, for each domain, state of the art, what is the evidence, state of the current services, what is the situation in the European countries, research and development priorities, what more do we need to develop in terms of research, and fourth, setting targets for the year 2030. So this is a steering committee. These are the domain chairs. There was one group on translational research, and on this group you see the different members in the working groups, and I think there was about 80 persons who were involved as authors of the declaration, and there were several instances where there were disagreements within the groups, that they couldn't make a decision. Sometimes Valeria and I had a diplomatic task to go step in and say that we have this solution, we do like this, and we arrive at the conclusion. So it was a tough work, but it was stimulating and it was worthwhile absolutely to do it. Research and development priorities also had the groups. So we arrived at 4 overarching targets. When we were looking at the targets, we found that there were several things that were similar for all the domains, and these are the 4 important overarching targets. First, we did careful calculations to reduce the absolute number of stroke in Europe. by what percentage, how much the absolute number, and there we have to take into account population growth, aging of the population, possible development of the incidence rates, and taking all the three together, it seems that it's reasonable to at least have a 10% decrease in the absolute numbers of stroke in Europe. This is important to decrease the number of strokes, or at least to have a steady state, because otherwise the health system, the stroke services, cannot accommodate the inflow of stroke patients. They will be flooded. There will not be a chance that there can be much increase in hospital beds. We need desperately to prevent stroke and reduce the number of stroke for the stroke services to survive in the long term. The second one, to treat 90% or more of all patients in stroke in Europe in a dedicated stroke unit as a first level of care. So here comes the importance of the stroke unit, a dedicated stroke unit, and not only at some time during the hospital course, but as a first level of care and 90% or more of all patients. So it's a high aim to have 90% or more patients treated in stroke unit, but again, this is probably the single most important thing if you want to build stroke services, is to build stroke units. Third, to have national plans for stroke. And fourth, to have national strategies for multi-sector public health intervention. And it means that you have national strategies for primary prevention, for healthy lifestyle, for blood pressure control, and the thing as a fourth overarching target. So I will not detail the targets now with you. I will just show you in a glance what was in the targets for the different domains. Here is primary prevention targets. And we go directly to the second one, organization of stroke services. And here you see we have managing and delivery stroke care by competent personnel and teams. We emphasize the education of the professionals and regular certifications or equivalent auditing processes. So there should be certification of stroke unit and the services. And there were a lot of discussions what type of certification. There's different in different countries. We finally didn't specify that, but we said that it should be certification of the units. So third, management of the acute stroke targets. So here we have again stroke unit, we have recanalization therapies, we have onset to needle time and onset to reperfusion time. We have two targets also for ICH and for subarachnoid hemorrhage. Fourth one, secondary prevention. I will just pass by that. Fifth one, the rehabilitation targets. And you can look on these in detail in the document if you want to have the details. And six, we come back to this important part that establishing national and regional level of systems for assessing, accrediting the clinical services. There should be a quality assessment built into the hospital system so we have data. Otherwise, you're absolutely blindfolded. You don't know what you do. You don't know what direction to take if you don't have the data of the services. This is absolutely essential. And seven, very important for the stroke support organization to have targets for the life after stroke, life for the patients, the situation for the carers, and all the society can do and what is needed in terms of follow-up and rehabilitation. I think there was a real strengthening of this part of stroke management, the life after stroke. So in contrast to the previous Helsingborg Declaration now, the European Stroke Action Plan has also an implementation plan, a clear plan for implementation. And what we focus now on in the implementation is to come down to country level, because we know that each country is autonomous when it comes to decision into stroke care and healthcare. You may have a regional agreement, you may have a European agreement, but the final decisions exactly how to do this is up to the individual country to finally decide and to make the decisions. So you do not get an implementation just by setting up a regional action plan. You need to come all the way down to the countries and to proceed and come to the country region and to the local hospitals to have the implementation. And this is really a very, very challenging progress. So this work has now started with also the component of sharing data for national and regional stroke quality register, monitoring of key performance measures, and implementation committee that has been formed and that has started to work. So the kickoff meeting now with the implementation, it was a bit delayed, but it was about 1 month ago with a virtual meeting with the vast majority of countries in Sweden represented at this meeting. So now there will be continuing work. There is very much focus to have data available. There is very, very much focus to have national stroke plans and to promote that, and also about the certification of stroke units. So far, this has not been specified because there are different regulations and practices in different countries. ESO has a certification process of stroke units. Is very demanding. You have to fulfill a very long list of items to be successful. And for most of the stroke units in regular practice, this will not be feasible to do. So you need to have another easier system for certification. So this is under discussion, but this is very, very important to have. So this is my last slide. I think this, again, this is wonderful work. This is very stimulating work. I think it's fantastic that this is now ongoing in Latin America, is ongoing in Europe, is building up in many other parts of the world. I'm sure that we will have very much to learn from each other in terms of good examples, in terms of looking at difficulties and how to come over obstacles. I think this is a fantastic phase now in an attempt to really implement stroke services and in particular stroke units across the world. So I wish you good luck with your work in Latin America and count on the full support from the World Stroke Organization, from the European Stroke Organization, from all of us who are here, that this is probably the thing which is closest to our hearts, is to establish stroke units. So thank you for having me involved here, and thank you, and over to you, Sheila. Goodbye.
Thank you, Bo. Wonderful. You will follow your steps because I think they are very important to build the whole stroke system of care in our region and in each country. So thank you very much. So now I would like to introduce the MT 2020 team. Violisa, Santi, I think they are here. I'm not sure about the Dilip. So I'd like to call them to talk about the Mechanical Thrombectomy 2020 initiative, working together for stroke centers qualification. So the idea is to join efforts across the globe to improve stroke care in our region. So I would like to call Dilip Yavagal from the University of Miami, that is the chair of this program, Santiago Ortega from the University of Iowa, and Violisa Ainoa from Sims Murphy Clinic. It's up to you.
Hi, how are you? How are you all,
Hi,
Sheila?
hi.
So I think Dilip is now joining. He was having some technical difficulties, but he just joined, and we will start sharing.
Hi. Hi,
Yes.
Dilip. Thank you for joining us. Thank you for your input in the process of certification too. I'm sure that working together will be better in the region. Thank you.
No, absolutely. Thank you so much for having me. Greetings to everyone. Greetings, Werner. And thanks for the opportunity. Would you like me to start my presentation or our
Yes.
presentation? Okay. Great.
Yes. Thank you.
All right. So I'm going to share my screen. So good afternoon, everyone. I'm Dilip Yavagal. It's a real pleasure to present at this exciting meeting and join this exciting initiative of certification of stroke centers in Latin America. Along with my co-chairs of MD 2020, Violisa Ainoa and Santi Ortega, we would like to just share what's been happening with Mission Thrombectomy 2020. And certainly Sheila and a little while ago, Werner have been leaders or are leaders of this initiative. So what I'd like to do is set the stage very quickly within about 6 minutes or so for Violisa and Santi to really tell you about the activities that gel with the initiative that GSA and WSO is taking in LATAM for certification of stroke centers. So we are rebranded as of a couple of weeks ago as MT 2020 Plus, and I'll talk about that. So the numbers are well known to everyone here. We have this disproportionate burden of stroke, mainly in the low and middle income countries, and this disproportionate incidence of stroke is what we also are prioritizing with Mission Thrombectomy 2020 to really reduce the disparity of access to stroke care that exists in the low and middle income countries, which have the highest burden. What we know and we focus on is thrombectomy, that thrombectomy is not only overwhelmingly beneficial, but also very cost effective. And this is the case even in low and middle income countries. What we see from this study in Saudi Arabia is that if they projected a shift in care from traditional care to gradually increasing uptake of more effective treatments over 10 years. And despite the increase in costs of thrombectomy in that scenario, the estimated cost savings was above 600 million over 15 years. And this is direct costs and indirect costs of caring for disabled patients and also the lost productivity. And this is the most exciting development that all of us know, that thrombectomy is now clearly proven to work in low and middle income countries, thanks to Sheila and her amazing team. And with that, what we have been thinking for the last 4 years in MT 2020 is that what is the gap in access to thrombectomy globally? And the estimates of LVO have actually just begun a decade ago, because before that, there was not really a need to focus on LVO. And what we know is that these estimates have a range. Initially, it was thought that it is around 10%, but now the estimates are in the range of 10 to 30% of LVO, of all ischemic strokes are LVO. So in the US, the top end of the range is felt to be around 200,000 strokes in the US. And even in 2016, the number of thrombectomies were only 20,000. Worldwide, even if you took the lower bound of the estimate of 10%, it yields about 1.7 million LVOs. And in 2016, only 100,000 LVOs, thrombectomies, I should say, were done. And so the question is, how can we close this gap? What can we do proactively? The bigger reason is that this treatment with thrombectomy and thrombolysis is highly time sensitive, and therefore the access in terms of time is critical. In 2011, only just above half of the US population was within 60 minutes, and a more recent modeling shows that we need almost 20 more thrombectomy or CSCs per state to have about 63% of the population within 1 hour with ground access. So the even in a developed country like US, to really increase access, a number of proactive measures, public health measures need to be taken. And in Europe, also there is a clear geographic disparity between Western and Eastern Europe in access to thrombectomy centers and even stroke centers for that matter. And so Mission Thrombectomy 2020 was launched to address these geographical disparities and to close the thrombectomy gap that exists pretty much globally. And what you see here is that estimates of the total number of thrombectomies done by industry have shown a steady increase. 2015 was about 10,000 thrombectomies in the US, which have grown to around 45,000 as of 2018. And the question is, can those be doubled to closer to 70 or 80,000? Worldwide, also, the numbers have thankfully grown. 2017 was about 79,000. 2016, I should say, 17 went up a little bit. And then 2018 was a decent jump of 156K. And actually, as of 2019, the numbers now, it's no longer projected. It's known that it was about 180K. I need to update that slide. And our goal for MT 2020 is to get that number. And we made that goal in 2017 was to bring it up to 202,000 to make it synchronized with 2020. So essentially, what MT 2020 aims to do is to double the effort, rates of thrombectomy every 2 years using public health interventions. So this effort was launched in 2016 by SVIN, and we've really had the privilege and great fortune of growing this global alliance, just like the GSA, quite well. So our overall vision and goals were stated early on, and we want to be a global metric-driven campaign that is not isolated, but really joins hands. So an umbrella campaign where we want to integrate the disparate knowledge of barriers to MT access. We want to unify multiple efforts by local and specialty societies to increase access. And as I said, we aim to double the access to thrombectomy every 2 years in every region. And we chose that because we know that some regions have very low numbers, and doubling it is what we felt was easy to target. And our goal was really for 2020 to reach a certain number. And what we know about the science of new treatment access, and this has been established by Rogers and Everett with a seminal paper in 1960s, where it takes about 20 years for 50% of the population to get access to a new treatment. And the idea that MT 2020 has is to use public health interventions, which are also well defined as interventions that can be very impactful in treatments that are treating a large health burden, that have a burden distributed unfairly, that have a disease, that have a treatment that's highly effective and safe. The treatment is cost effective. And what we have evidence is that upstream preventive strategies, like upstream strategies such as increasing EMS access, could substantially increase access to effective treatment. And these strategies are not yet in place. And so we felt that thrombectomy really met all these criteria, and we wanted to use this approach in public health policy where we would target economic, political, and community factors to increase access to thrombectomy. And the goal would be to really shift this well-known curve to the left, and instead of 20 years, perhaps make it 10 years where 50% of the population has access in both developed and developing countries. And so we are working with well-established scientific principles that have clearly shown that there are 3 pillars of access. information and diagnostic access, where the community including physicians and non-physicians need to know about LVO and about thrombectomy, and the diagnosis can be made quickly. We have the pillar of physical access, where a community has facilities that do thrombectomy and experts, and then the barrier of financial access, where clearly this needs to be paid for. And so what Mission Thrombectomy aims to do is work on each of these barriers by accelerating diagnosis measures, by accelerating physical infrastructure, and by accelerating financial ecosystems. And certification very much falls in the number 1 and number 2 pillars. And that's why this is very exciting to be part of. And so I'm going to stop there and have Violisa tell you about how MT 2020 has gone forward with these principles and put together a number of activities and regional committees in place. Thank you so much. Violisa, if you want to go ahead.
Absolutely. Thank you, Philippe. Thank you, everyone. Good afternoon. Let me start sharing my screen. Can you all see it?
Yes.
Yes.
Thank you. Thank you. So, well, thank you again. My name is Violisa Ainoa. I am the Global Coordinating Co-Chair for MT 2020. I would like to thank you all for this opportunity. Thank you, Shayla. Thank you to the WSO and the Global Stroke Alliance for giving me the chance to talk about MT 2020 Plus. I will go over the organization of MT 2020 and our regional committees with our future tasks. So this is the organization chart, and this is how we look like. Everyone is part of what we call the Global Executive Committee. We have a core leadership committee based in the United States with Dr. Yabaga as the chair, and 3-4 other people acting as co-chairs of the MT 2020. And then the core leadership committee actually comes up with different activities and the interventions for MT 2020. We have 8 co-chairs across the globe. And these very experienced physicians actually help in developing and supporting the implementation of our health initiatives. We have our task force, and that is the regional subcommittee. So these physicians are in each region, and they will implement the health initiatives that we are planning. So there's a country liaison that lives in the United States, but helps with the communication between the core leadership co-chair committees and the regional subcommittees. And we also have assigned co-chairs to different regions in the world, so we can actually oversee what the regional subcommittees are doing, and we can track how these initiatives are being implemented. We have a lot of support for SVIN, as Dilip was mentioning, and also we have aligned with multiple societies such as the WSO, the Global Stroke Alliance, ASA, AHA, and with stakeholders across the globe. So this is how we are in terms of the renal committee's organization. We were able to have a meeting that permitted the launch of these renal committees about a month ago. And that was quite impactful. That actually helped us recruit more members. And we have formed 30 committees already, and we are in the process of forming 52 more committees. We have more than 200 members, and we are in communication with other members at this point. So our numbers are getting up rapidly, and we are in the process of recruiting about 350 people at this point. So the majority of our members are from Latin America and South Asia, and that is followed by the MENA region in North America. So just to give you an overview of the activities for this past year, we were able to meet in person at ISC this past February 2020. And we were able to have this in-person meeting that was attended by people from pretty much all continents. We were able to talk about the stroke treatment state in different regions, and we were able to learn about what is the development of the stroke treatments and mechanical thrombectomy in their different regions and different countries. We have expanded, as I said, our GEC to more than 200 members, and right now we have representation from 82 countries. One of the main things we did was to develop a COVID-19 stroke thrombectomy survey that is in the process of being submitted for publication within the next month. And there was another survey for the stroke coordinator committee, which actually was also developed a couple of months ago. And this is being led by Dr. Anne Alexandrov. One main thing that we have been working on is the finalization and implementation, distribution of the white paper. Dr. Santiago Ortega will talk about the white paper in detail during this meeting shortly. The title of the white paper is Mechanical Thrombectomy for Acute Stroke Care, Building Stroke Thrombectomy Systems of Care in Your Region, Why and How. And this is meant for health policymakers across the globe. So in 2 days from now, we will be launching our app, is Mechanical Mission Thrombectomy 2020 smartphone app, which is a real-time global thrombectomy tracker that will serve as a case log, but also the main purpose is to help us track down the number of mechanical thrombectomies that are performed by interventionalists across the globe that are part of Mission Thrombectomy 2020. So to finalize, I want to give you a briefing of our plan for the rest of 2020 and part of 2021. As I said, we plan to distribute the white paper, and this has been finalized. The Global Thrombectomy Tracking app will come out, as I said, next week. We plan to launch a regional survey that we will distribute across the globe to the regional committee members. And the plan is to analyze what is happening in terms of mechanical thrombectomy in different regions, to try to understand the volumes and to know the infrastructure and how the treatments are happening. It is a major priority for MT 2020 Plus to continue to develop public health interventions to increase thrombectomy access. And in order to implement these PHIs, we will continue to communicate with our regional committee members. And we feel that this is where this big initiative in developing stroke units at a regional level kind of fits the mission of MT 2020. We believe that by developing stroke center certification pathways, we could customize what has been already developed for the Latin America region, and we could share that with our regional committee members across the globe in order to continue to work on this stroke units and continue to develop, I wanted to say, a standardized stroke care in stroke patients. So with that, I would like to leave the Zoom meeting to our partner, Santiago Ortega. He is one of our co-chairs for the core leadership in MT 2020. He will be talking about the white paper. Thank you.
Thank you, Violisa. If you may allow me to please share the screen. Thank you. And let me just put quickly my presentation here. And I'm gonna just conclude this wonderful presentation to kind of give you a little bit of an introduction of the white paper that we are planning to launch this Saturday. And basically, as previous speakers have mentioned, we had an amazing therapy for large vessel occlusions that showed quite evidence, wide stroke evidence that was fairly helpful for patients with acute stroke in the developed advanced countries. And then I think the group from Brazil, I think actually demonstrated that that therapy, even applied in a public health system, shows very similar evidence that is as strong as we found previously in 2015, which means that we need to kind of implement this therapy to help these patients. And as Dilip said, usually when we apply a cost-effective, high impactful therapy, there is a pathway we can follow. And these are the pillars that we really want to kind of follow to get access to mechanical thrombectomy. Information, availability for the providers and the patients to know about the disease and to know how to diagnose it. Physical access, not only just for the experts to perform it, but also the centers and that are part of stroke centers to implement this therapy, as well as have the ability to have the devices and equipment necessary for it. And very important, and I think that's the purpose of the white paper, we have to have the ability to be paid for, or to pay for that therapy, which in this case, it can have a high upfront expenses, but as we are going to see shortly, it has a very cost-effective outcome for patients as well as for governments. And the purpose of the white paper was to provide policymakers. This is not a scientific paper as we write papers about studies. This is more for policymakers to provide data that why treating LVOs can help patients at global, national, and regional levels, independent of the outcomes. And the purpose will be to have 3 versions for high income, low income, and very low income, adjusting for specific resources. The main aims of the paper is educate about mechanical thrombectomy, recommend the setup in different countries depending on the resources, and encourage the policy makers after they see the evidence to improve implementation of mechanical thrombectomy for reduction of the stroke burden. And the paper has 4 main categories. The first category, we're gonna inform the policymakers about the incidence of a stroke and LVOs, which working together with the global executive committees and the leaders of each country. This is just evidence and guidance to help to kind of penetrate better into the respective country governments. And we're gonna kind of also try to address some of the challenges, common challenges of implementing this therapy. As we talked about, we're gonna try to identify work on the pillars for implementation and identifying the problems. And then we are going to actually, this paper provides a lot of evidence, not only of the medical aspect, but more importantly, the cost-effective aspect that independently of the country, it's been shown that there is approximately a $12,000 or 10,500 euros benefit for each patient that undergoes mechanical thrombectomy when it's indicated, and also a very prominent improved outcomes and better quality of life for those patients. In addition to that, the third part of it is going to also talk a little bit about what the previous speakers have talked, which is kind of how to implement this therapy based on some of the leading societies, learn from what they have already built, and how can we apply those stroke centers, those qualifications to different countries. And in this case, I think this specific project that Sheila is leading about the stroke center certification is something that we are really humble and proud of helping out, because really this is an opportunity to really utilize the knowledge of Europe, the knowledge of Australia, US, and really kind of implement based on the different countries to also partner to implement the advanced mechanical thrombectomy therapy for those centers. And finally, in the last part of the paper, we give some basic policymaker recommendations that we learned from experts in the field that have helped to kind of polish the paper, as well as some previous well-documented evidence that have worked in other countries and continents. Then we are going to talk a little bit more in detail this Saturday about it. Everybody's invited. This is the link to join the meeting. We're going to launch it for the first time, and we will share with the global executive committees in each country with the co-chairs to start kind of working together to see how we can really help to develop further stroke care in their regions. Thank you so much for your attention, and thank you for the opportunity, and obrigado and felicitaciones.
Thank you, Santi. Great. The idea is to join efforts to implement all levels of complexity, and the comprehensive stroke centers are important too. So thank you for your help in everything, and including in the documents for certification. Thank you. So now I will share my screen to talk a little bit more about the certification. The idea is to work together with stroke national societies or neurological societies and country leaders in the planning for the certification, as you did in the last month. So we circulate the criteria for certification among the group, and we have several inputs. We are working on that yet, but the idea is to apply for certification. For some reason, he's working alone, but to apply for certification, you have to fill the hospital's classification form according to the roadmap. All items considered minimal requirements to apply for classification in each category are mandatory, I will show you, and beyond the minimal requirements, hospitals will need to reach at least 85% of high priority criteria, high priority elements, and 60% of lower priority, but still important elements to get the Latin American Stroke Center certification. In the second certification, the centers will need to reach 85% of high priority and at least 70% of lower priority elements. As Werner told you, you need to improve the qualification each year. Also, we have to show improvement in the quality indicators, because it's mandatory to have a registry in the hospital to measure quality indicators. So the second step, the electronic interactive resource will show the proportion of resources available in the hospital according to all suggested in the roadmap category prior to the visit to evaluate potential candidates. Marcio is working on this. Marcio Rodrigues worked with me here. He is doctor, but he is TI specialist too, and is working in a tool to be used in this process. Is almost ready. Marcio, you show an example here, Marcio. Marcio, are you connected?
Sorry, I was muted.
Okay.
So thank you, Sheila. I'm very lucky to work with Sheila since the beginning of the first stroke unit here in our city. I worked with Sheila for like 15 years now, and I'm very pleased that she invited me recently to make this dashboard. So I worked with the municipality of Porto Alegre here in Brazil, and I've been collecting information about healthcare in the city and in the state, and I think it's a wonderful project, and I'm very happy to be part of it. So I'm working with this in this tool in order to collect the information from the stroke centers who are applying for in Latin America, and also I'll make these dashboards in order for you to check which ones are working and they're working in progress. And I'll be very happy if I could have some inputs from other centers around the world. In which tools do you use to collect this kind of information? So I think I'm just showing some work that I do in the municipality of Porto Alegre. You can pass this, Sheila, please. This is the COVID that I've been working with, and I hope I'll meet the expectations of the group. Thank you very much.
Thank you, Marcio. He has a wonderful work on this, and I'm sure that will help us a lot to put this electronically to help us. So after fill the form and see the criteria, we will have an on-site hospital evaluation. As Werner told, we need to see if it is real what is in the paper or in the electronic form. So we will review 10 patients included in the registry, comparing to the hospital records and review the quality indicators. We also will review the patient's pathway, visit emergency room, intensive care unit, stroke awards and unit, angio suite in advanced centers, and meet with the coordinator of stroke center and other professionals from hospital and emergency room, as we have in other certifications, to evaluate the reality in the center. The evaluators will point potential deficiencies areas of improvement, and centers will be asked for action plans to improve the service to be presented in the next certification. 1 year after one on-site certification, the hospital will be evaluated for recertification. And after this, to maintain the certification, each year, the quality indicators will be reviewed online, and the hospital will be visited for recertification each 2 years. That is initial idea. We are discussing about this. Well, about the essential items, mandatory items for the essential stroke services. Protocols for rapid evaluation and diagnosis of stroke patients in hospital emergency department, 24 hours, 7 days. Stroke unit as a defined group of beds, staff, and protocols, or for this essential, as we are starting, we can accept clustered model of stroke unit on same wards. Access to basic diagnosis services, laboratory test, electrocardiogram, CT scan, 24/7. As Werner told, this is mandatory. CT scan should be 24/7. Echocardiography and Doppler ultrasound. I know that some countries don't have available ultrasound. We'll discuss about that. Acute IV thrombolysis, 24/7. Neurologists with expertise in stroke, as we have in Brazil and Chile, including acute stroke in countries where stroke care is primarily led by other medical specialties, or countries without enough neurologists, and depending on the National Neurology Society or Stroke Society or Ministry of Health, this can be stroke physicians, as we have in Europe. So physicians with proven expertise in stroke, and we will have the definition and documents to prove expertise in stroke. Members of interdisciplinary stroke team, the minimum is nurse with training in stroke, nurse assistants, physiotherapists in language speech therapists, dysphagia screening, of course, and participation in quality assessment of services. So we have the minimal quality indicators in each service. We have a checklist. I already told you about this. In the first certification, 85% of high priority should be achieved. And also 6% of lower priority. In the second certification, the lower priority should achieve at least 70%. So I already told a lot of them, but we have other important elements here. If you have emergency medical services in the region, we have training ambulance crews and have worked with ambulance systems to have stroke identified as a high priority. So this is part of the whole of stroke center. You have, we need acute care settings, trained nurses. So for the first one, we don't need certification, but for second certification, we need nurses trained with certification for this. And also nurses trained for stroke unit settings. Access to neurologist, I already told about this. Stroke unit or clustering model, IV thrombolysis. Here is the interdisciplinary stroke team. Of course, we have some ones that are mandatory, but we would like to have all interdisciplinary stroke team available. We have to use all protocols evidence-based from stroke units is very important. Early access to rehabilitation therapies is important too. And here, interdisciplinary meetings weekly, patient and family education, discharge planning, coordinated stroke care provided across geographically discrete regions, stroke training programs, and quality assessment, I already told you. So this is the list. And for advanced, we should have also MRI, CTA, 24/7 CTA, and we can have CT perfusion, but it's not mandatory. Transcranial Doppler and prolonged EKG monitoring devices. In advanced stroke centers, we need neurologist, neurosurgeon, neurointerventionalist, of course, and intensivist is important too, and physical rehabilitation medicine. We need a stroke unit for advanced, the full interdisciplinary stroke team, and access to advanced interventions, as Werner told you, endovascular thrombectomy, neurosurgery for hemorrhagic stroke, hemicranectomy, acute inpatient stroke units, intensive care unit on site, and produced to reverse coagulopathy. And you have to coordinate the all region network that is very important to improve the care in the region, and implement research in the stroke as a criteria to be implemented too. So the idea is to collect quality indicators. You can use rescue and CIDS-QR because you already have 300 hospitals, including patients in these registries. They are free, or you can use national registries too. We will discuss this with in each country with neurological society and stroke leaders. Otávio, could you talk about the criteria for quality indicators that we are using in ANGELS program, but they are international criteria created by Werner and other international stroke physicians, Valeria Caso and Ken Lee. Otávio?
Yes, thank you, Sheila. So thank you everyone for being here. So basically, these are already being used by the ANGELS project, ANGELS Awards in Brazil and Latin America. So the number of patients treated within the time from door to needle in less than 60 minutes. And then you see the different levels for the gold, the platinum, and the diamond. You have the percentage of patients treated within the door to needle less than 120 minutes. Percent of patients treated within the door to needle less 45 minutes. The percentage of patients treated with door to needle in less than 90 minutes. No, door to puncture in less than 90 minutes. The percent of patients that were treated with recognition among the incidence of stroke in the hospital that achieved recognition. The number of patients that there was a suspicion of stroke, and among the patients that received a tomography or a MRI during the procedure. The percent of patients with stroke that had screening for dysphagia. The percentage of ischemic strokes that get antiplatelet agents during the admission, the percentage of patients that had atrial fibrillation that get anticoagulation during the hospitalization, and also patients treated that received treatment within the acute stroke unit or an ICU during the admission. And you can see that there are different thresholds in each level, right? And we are ready to improve, to include a few other items in a bit. So to be included are the arterial puncture 2 recognition time. This will be included, and also the final TICI score after thrombectomy. So those are important also indicators that will be included in soon. Yeah, you can go, Sheila.
Rescue some improvements in the criteria, and maybe Werner, Bo, and Perry can help with this too. Well, we need the registry to be certified, and during the time we need improvement in the quality indicators. So it's very important to resource for education. Patty already told about the World Stroke Academy. We have several resources there. We have a Latin American teaching course, but it's not complete yet. And we have local resource too. Gisele, could you talk a little bit about the Angels resorts that we are using in several hospitals in Latin America with very good results?
Yes, Sheila, thank you. So it's a great pleasure to be here. So as we all know, Angels has been a great initiative with the support of more than 50 national stroke societies. So the idea is that we don't have to create new resources. We already have it, and you have, help in order to apply those resources and to educate, all the healthcare workers that are treating patients with stroke. So the Angel initiative includes training in patient care, evaluating and treating patients in the emergency service, as well as evaluating CT scans, which is actually very important when we're dealing with patients with stroke. And you can do it all online. So that's the good thing. Even during the pandemic, we can still be educating our physicians and our nurses and all the healthcare providers that are involved in stroke care. So we have models that focus on the implementation of the stroke service and on the standardization of the care for the patient with stroke. So including education for ambulance pre-notification. So the idea of taking the patient direct to CT, of doing pocket testing and treating the patient at the CT scan in order to be quicker and to improve the prognosis of our patients. So this education tool does include Body Interact virtual simulations, CT scanning learning simulators, which is actually very important. So advanced stroke life support certification, slide kits as that we can replicate it in our own language, especially a training for nurses and expert panel discussions. So this is an example of how we can train our physicians in order to interpret CT scans. We know that in not all services we do have neurologists at the emergency department and to evaluating the CT scans. And the education for nurses is also very important. So for the model educating nurses, we have more than 9,000 nurses enrolled, and more than 7,000 nurses have already completed the 20 models of the training resources of Angels.
The resources are really very good and are helping us a lot to have nurses certificated and doctors trained to assist the stroke care. So the idea is to use these available resources. Pedro, thank you, Gisele. Pedro Magalhães will talk a little bit about other tool that was created in Joinville for our first stroke unit in Brazil and supported by Medtronic. Pedro?
Hi, thank you very much for the opportunity to be here, and it's a pleasure for our team here in Joinville to be working with Dr. Sheila in this huge effort to decrease the inequalities of stroke care in Latin America. So I'd like to present this educational tool that we have developed for stroke centers in Latin America. And many services in Latin America do not have access to educational resources on stroke. Maybe it's not a problem for doctors because most are specialists and have received formal training, but the multi-professional team has some barriers to access educational stuff. So we created this material, this course for all the team involved in stroke care. So it's a partnership with Medtronic that allowed the creation of a complete and free training program that I'd like to demonstrate to you. This course all the staff was formed by stroke neurologists and interventional neurologists with a background in neurology, so everybody here understands the importance and the needs to implement stroke units and the whole stroke care pathway in Latin America. And our challenge was to translate the best scientific evidences to be applied in this harsh health scenario in developing countries. So this is a 10 module with fully with material in Portuguese and Spanish, and it has each module can pass, please, Sheila.
Sorry.
Each module has video content, all the slides that have been presented in the video class, and also a lot of material for download. Please, you can go. So in the end of each module, the trainee can reach complementary materials with videos and also real clinical cases and questionnaires for self-assessment and certification. And we hope to help services in Latin America to improve the quality of care in stroke. And that's the aim of this project. And we are very, very honored to be presenting it here. Thank you.
Thank you, Pedro. Really is a wonderful material that can be used to any country. And we have local resource also in Chile. They have a wonderful training online teaching course from the Ministry of Health. In Brazil, our society is creating a course, but for specialists. So we can use all these tools to train the whole stroke team. The idea is shared with all the committees in each country, the initial proposal, and implement very soon, because now the idea is to implement now, and working together, I'm sure that we are stronger. So I'm very happy to see here today more than 50 Latin American leaders discussing this very important project. And thank you for everyone to being here. And I'd like now, before to start to show the delegations in each country, just run a short video with the delegations before we start the country's presentation. Lucas, pode rodar o vídeo, então? Bom, pessoal.
So we're back. The idea now is that we can speak Spanish and Portuguese. Carlos Catu is here, our future president of Ibero-American Society. Next week, he'll be the president. And the idea is to introduce the Brazilian delegation, my friends who are here. It's a huge pleasure to have with us the president of the Brazilian Academy of Neurology, Professor Carlos Rieder. Thank you, Sheila. It's a pleasure to represent the Academy here, Brazilian Academy of Neurology, and congratulate the organization. Wonderful work. It's quite clear that certification will improve care. It's evidence-based. It will improve mortality and outcomes. We, as Brazilian Academy, what we can do is support. It has been mentioned the importance of the manager. So I think the Academy is really important, and also to contribute in this continuous education. So again, I have to thank the Brazilian, on behalf of the Brazilian Academy, and also congratulate Sheila and everybody. Thank you, thank you, thank you. Now I would like to call Francisco Montalberni, then Marcos Landi. Francisco Montalverni. Good afternoon, everybody. It's a huge satisfaction to be part of this cooperative work with many specialties to ensure excellent and equanimous treatment for all the patients with stroke. What we will try to do is to ensure this equity, understanding that neuroradiology nowadays is a key part of serving those patients. And we are partners that are in balance with neurovascular specialists to solve this.
Thank you very much. Carlos Clayton now, who is the current and future president of the society. No, 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 not at all. I am only a collaborator. Good afternoon, everyone. It's a great pleasure to be here taking part in this joint effort on education, accreditation, and professional training, which is all towards the improvement of our patient care. This is our main goal, to give the best possible service to our patients. Just to complement a little of what Frances said regarding our practice in Brazil, we are now in the movement of strengthening of society as training centers and specialist centers. We have 15 such centers, 15 to 18 professionals who are inserted in the market, so to speak, in the society, who can help in this work group against strokes. And so they are prepared now to take on this challenge. Thank you very much. Thank you. Now, Pedro Magalhães, who has worked and helped a lot in the elaboration of all this material for certification. Pedro, please introduce yourself. Good afternoon. My name is Pedro Magalhães. I am a neurologist and neuroradiologist. We've been working for a long time in a service together with Sheila and other specialties in Brazilian Society of Radiology to create certification parameters of ongoing quality improvement for the service provided to stroke patients. It is our obligation, not only professional, but it's a humane issue. It's a humanitarian mission of ours for this to to manage this disease in Latin America. Thank you so much. Gisele now. My name is Gisele Sampaio Silva. I am a neurologist. I am the General Secretary of the Brazilian Academy of Neurology. I've been working very close with Dr. Carlos Hayden and Sheila in the Federal University of São Paulo and the Robert Einstein Hospital. I'd like to say it's a great pleasure for me to be here. I think it's a landmark, it's a hallmark for us to standardize the treatment of stroke. That we know that time is of key importance in this disease, in this condition, and we depend on certification. I think this is a great step for us to improve our care of this disease, which is the second most frequent cause of death. I think it's our mission is academic and also humanitarian to understand we have several patients who are helped in our public healthcare system who deserve the same level of quality care as other patients who go to private centers. So it's a great pride and privilege to work with you. I think it's the beginning of a beautiful journey for Brazil and Latin America. Thank you. That's wonderful. Now, Otávio. My name is Otávio Pontes. I am a neurologist. I'm the president of the Brazilian Society of Cerebrovascular Accidents, and I coordinate a group in the Clínicas Hospital in Ribeirão Preto. We've been working towards expediting this pathway towards certification. I think this is a hallmark in the history of vascular neurology in Brazil and in Latin America. It is an old dream of ours to have a certification plan that is implemented horizontally throughout the country ever since the publication of the Bill of Law of 2012. I think this is another day to be remembered. I think it's one more date to be kept in our memories because this effort will certainly provide many good results. I think it has to do with accountability for us to look for certification and quality parameters in the context of stroke. No isolated intervention should be looked at. We should look at things as a host of topics. And I think with this team so passionate about this topic, I think this is really a hallmark in the stroke field, so to speak, in Latin America. Amara Amelia, I'm not sure if you are connected with us. Rodrigo, are you there? Rodrigo, please introduce yourself. Good afternoon. Congratulations, Sheila and all the team. My name is Rodrigo Bazan. I work at Unesp in Botucatu. I am the coordinator of our stroke unit. I am in the team of the Brazilian Stroke Society together with this great team. And I will help in whatever is necessary. Count on me. Thank you. I think Leticia and Amalia are not present. They are also part of the Brazilian Society. Has Michelle logged on? So Marcos Lange, the president of our Brazilian Society of Stroke, he will talk to us about what the situation is like and what we can expect in Brazil. Thank you, Sheila. Thank you all. Do you read me? Wonderful. Leticia and Maria, they were logged on. Maybe they left for a little bit. But first of all, I'd like to congratulate the initiative, the Iberian Brazilian Society of this. Well, they have engaged in involving all of Latin America in this certification project. And I think this is a priority now, and it will be a water divider. Europe did that 25 years ago. We have 25 years ahead of us, therefore. We'll all have gray hair, and anyway, it will be a huge effort. I am sure Brazil has done part of its homework in 2012, as was said, with the creation of the first law. Then several units were created. We know that Brazil has a public healthcare system that 70% of the population depends on. And even though we have islands of knowledge, as a friend of ours says, we know we have a lot of work to do, but a huge part of it has already started with the creation of these stroke units. At that time, we already had the need for quality indicators, and we need to strive to meet that goal. Since then, we had another water divider last year with the publication of the Resilient, which was when the Charter of Gramado was done too, which strengthened this joint effort from Latin America. I think 11 countries are present here now. So it's an honor for us Brazilians to be part of this union in Latin America to try to make an impact on the stroke situation in our continent. And as many have said in their presentations, I think this is a line of care. So not only the stroke unit, but secondary prevention, rehabilitation, and primary prevention. Most importantly, all of this work will lead us to reduce in the coming years mortality and morbidity of stroke. So I am Marcus Langri. I am a neurologist. I work at the Clínicas Hospital in Curitiba. And it's an honor for me to be presiding the society in our country. So I'd like to thank our colleagues, the members of the Brazilian delegation. I'm sure that together, all of us, with the partnership of other countries, will improve ever more the stroke patient care in Latin America. And may it not take 25 years, may it be sooner. Perfect. Thank you, Marcus. Excellent. So to give you one piece of news, we have about 400 people connected here. Here we have 10 countries, but we have people from all over the world watching us, and we're very happy about that. Carlos, I'd like to pass the floor to Carlos Tantu to call the next delegation.
Good afternoon, Sheila. Excellent work. It's a pleasure to be here. And we are from Mexico. We are the ones that are really struggling with all that. And I want to congratulate you all. So we're going to start with the Latin part in Spanish. And I would like to call the Argentinian delegation, Leo Gonzalez, Sebastian Amerizo, and Matias Alet, to start, introduce themselves, and then go on. I don't know if you, Sebastian or Leo. Matias begins. Good morning. Well, thank you for the opportunity. We also have Dr. Chavez and Dr. Guadalupe here. It's a pleasure for us to participate on this initiative. And it's something that we have been wanting for a long time. And to organize in Latin America, all this is fantastic. So I'm going to introduce my friends here who are connected from the Argentina Neurologist Society. Dr. Leo Gonzalez. Good morning, everybody. I'm Leo Gonzalez, and I'm from the Neurologic Society from Argentina. And I work in a public hospital in Buenos Aires. This is where I work, and I think it's very important to have the possibility of putting together Latin America and decrease this inequality that we have in the access for stroke patients in our countries. And we also want to thank the invitation to bring this better treatment of stroke to Latin America. Guadalupe. Thank you, Leo. Guadalupe. from Argentinian Neurological Society. Well, good morning, everybody. Can you hear me? Well, thank you, Sheila. Thank you, Leo. It's a pleasure to be here with all of you. And soon, what I would like to mention that I think is very important is that Latin America has something in common, so much in common. In this meeting, we'll start to make the gaps smaller in all the countries here represented. In public and private sector, it's very important that we all get together to work jointly for sustained work. Today it's me, tomorrow it's somebody else, Sheila, other people, Sebastian, and everybody who's been working in this. We need a continuum. And I'm very thankful to have the possibility of doing this. We are going to do everything we can in Argentina to work together with Latin America. I work in Rosario, which is a city that's not in Buenos Aires. It's a large city, Rosario. We have almost 12 million people there. And I work in a unit, in the vascular unit, and also I'm the head of the neurology department, but our titles do not matter. My opinion is that I want to really thank you all for this possibility. Thank you, Guadalupe. And now Dr. Hernan Chavez, Argentina Society on Radiology. Good afternoon. Thank you, Matias. I'm a radiologist representing the Radiology Society here. And I have been working for 10 years, and it's an honor to participate and be part of this delegation. And I share entirely what our friends have shared here. I also have the same view, and I'm very excited for this proposal in relation to the type of attention we're going to give the patients in every aspect. So thank you. Thank you. I would also like to mention that the Argentina delegation has members of other scientific societies, and we are quite plural. We have Dr. Gabriel Percy, who is a cardiologist, Dr. Maria Fernanda Diaz, intensive care, all of them representing their societies, Dr. Camargo, who is a clinician, represents Argentinian Society, Dr. Mamani, neurosurgeon representing Medical Society, Gustavo Macenga, neurointerventionist representing the Argentinian College of Neurointerventionists, Dr. Flavio Requejo, neurosurgeon, representing the Argentinian Association Neurosurgery, and Dr. Margarita, who represents the Argentinian Society of Gerontology and Geriatrics. And I give the floor to Dr. Sebastián Merizo, representing the Neurological Society. Good afternoon, everybody. It's a pleasure to be again with so many friends, old friends, and seeing that thanks to the initiative and to the work of so many people, we organize something that is so necessary for this type of diseases, so necessary for our patients, which is taking this care of stroke and cooperate among everybody and taking this care to our region, to everywhere in our regions. We have, there is no other region in the world that has so much in common. And I believe that this is one of the advantages that we should use, it's a titanic work. It's not simple at all. And I talk on behalf of my country, and the truth is that we try to do a lot to have this type of procedure there. It's not just gathering papers and hanging them on the wall, but really to believe and to certify the capacity of each place to treat this devastating disease. And it's not going to be just our impression of what we do, but it's going to be based on information from experts and colleagues to see whether you can really take this work forward. We're going to help one another to level everything. And we want to avoid inequality and improve quality of care. Our cooperation in that, as has so well been said by Dr. Matthias Allet, we want to incorporate everybody who works with this disease and all scientific societies that are involved in work in the sense of bringing the correct policies into place. And we believe that it's going to happen. What's important in this project is that it starts. Once we start to certify centers, and then we see this cascade event, it's good that we start so that the examples will motivate other people and show the need to be involved on that. So this is so welcome. I wish you all luck. And all my friends of Latin America will be working together. Thank you and congratulations to Carlos for his new role, so much deserved. And also Sheila, congratulations, Sheila. Thank you so much. Now I would like to call the Chilean delegation, my friends from Chile. Irvin is there. Pablo, I could not find you. Hi there. I'm very happy to have you here. Vitor, Enrico, Rodrigo, Claudia, so happy to have you here with us. And thank you for the input you gave us and for all the importance Chile has as a model for all of us. So I would like you to introduce the Chilean delegation.
Thank you, Sheila. I'd like to introduce the Chilean delegation and thank everyone for the energy, the impulse, that everybody's dedicating to this. I'd like to congratulate you on the election, and also my friends and colleagues from Latin America and from the world. We are all working for the same purpose. I'd like to say that the Chilean delegation has many colleagues, all of them younger, much younger than me. So it is the new generation which is now taking over what will happen from now on. And it's very proud to introduce them. And if we have some time, we can discuss what we are working on. We're working with the ministry, with us neurologists. We have some work in networks of care and complexity centers, specialty centers, and certification will be a key step, as all the speakers were saying this morning. And I'd like each of them to introduce themselves. We have Irvin Santos, Enrico Masson, all of these representing the Ministry of Health. And well, we have people from public hospitals, interventionists, and the Chilean Society of Neurology. And also, we are very happy to tell you that we are ready to begin the Chilean Society, Chilean Stroke Society, as one more agency or organism to help in that, in meeting our goals. So, Irvin, can you start? Thank you very much, Dr. Lavado. Thank you, Sheila. Thank you, all the organizers of this great meeting, and congratulations, because I see that we are taking a step forward, ever more forward. We have ever more colleagues and countries involved. I am Irvin Santos. I am a neurologist. I work at the Public Emergency Hospital in Santiago, Chile, and at the Ministry of Health in Chile as an international assistant for stroke. I am proud to take part in this group, this very diverse group. We don't have only doctors, we have a nurse too. We have people from the private and public context. So we have people from many regions as well. Thank you. Enrico? Good afternoon. My name is Enrico Masson. I am a neurologist, and I also have a degree in vascular neurology. I work in Santiago at the German clinic at the stroke treatment unit, and I also work in telestroke unit. It's a health service from Santiago, but we work with 7 hospitals all over Chile, encompassing a very broad territory, as Salanio said. And I, of course, am very thankful for the invitation and for being able to participate in this group and cooperate for the improvement of quality and management of stroke all over Latin America. Thank you, Enrico. Now, Rodrigo Rivera. Hello, everyone. Good afternoon, Sheila and all of the team. I'm very thankful to be here. It's an honor for me to participate. I am Rodrigo Videira. I am a neuroradiologist in Chile. I am Chief of Neuroradiology Service at the Neurosurgery Institute, one of the main centers for vascular management in the country. And I also work at the private clinic Santa Maria. So I spent a long time on our specialty. We try to have the service available all over our territory, which is very broad. So, like I said, it's an honor for me to be here. Great pleasure. Danielle Andreu. Good afternoon. My name is Danielle Andreu. I am a neurologist. And it's a big honor for me to be here. So exciting to be so many known faces. Thank you so much, Sheila, for everything you've been doing. I'd like to thank my Chilean colleagues. And like I said, I have a lot of enthusiasm in this. And we are all very excited about participating in this. In my case, I've been coordinating a work group on stroke in our society. We are a group of young people with a lot of willingness to work and to do things. So it's a great honor to participate in this. And we always have the example of Europe and the US, and this is what we're doing here has to be like what you are doing. So we want to be also as good in our region. We have a very rich region. I think we have many things to learn from you. Thank you. It's an honor to participate. Thank you, Danielle. Vitor Hugo. Hello. Good afternoon, everyone. My name is Vitor Bonavia. I am a vascular neurologist. I work in Santiago, Chile. And we have thrombolysis 24 hours a day, 7 days a week in one of our hospitals. And we have thrombectomy as well. So in our stroke unit, it's been 15 years that it exists. And it was the first national unit. What seems to be important and is to be able to generate, to work with the academia and with our patients to be in a context where we can generate outcomes and results and achieve results and ask patients for their opinions. Because what we do every day may be significant to them, to those we are caring for. We are also working with work groups to have an improvement in the quality of life of our patients, and in order for rehabilitation to be effective. So I thank you for the opportunity. Thank you, Vitor Hugo. Claudia Figueroa, our nurse. Are you there? Yes, do you read me? Good. My name is Claudia Figueroa. I am a nurse with 4 years experience in the public hospital in Chile. And we have a center that has thrombolysis and a center that has thrombectomy. It seems like her audio isn't so good. Well, let's see if we can get her back. But in the meantime, Rodrigo, are you there? Hello, my friends from Latin America. It's an honor to be here. It's an honor to be part of the National Coordination for Accreditation. It's a good country. We're working with, it's important to be able to have access to the quality treatment for our patients. We are working this year with local initiatives, and we have a document which is the model of care for stroke, which goes from early screening, management, and emergency. The early detection and hopefully the reinsertion of this patient into society as well as he was before. So we always have, well, our work is patient-centered, I would say. And for Chile, it's an honor to be able to participate in this network, in this delegation that has so many experienced professionals. I can't name them all, but I'm seeing some known faces here, professors. Well, I thank you all for the opportunity. Are you connected? Is Arnold there? Rodrigo, this topic is extremely touching for us. For those of us who are from the old layer, say, to see this new group of people coming in and being multiplied and having such intellectual power and such willingness to have to work, and they are so strong, and this indeed is what makes us proud and gives us a certainty of what we want to achieve, because I believe Paulo, Sheila, and I believe Carlos, all, for us, it would have been very frustrating if all the effort had been extinguished. And if we did not have this, what we are testifying now, many young people, men and women, full of vitality and with great intellectual capacity, so willing to work. And this really will have an impact in our patient care. And a couple of days ago, I saw I had an interesting discussion whether public policies were more important than personnel. And I am fully convinced that people certainly change public policies. And I stress the importance of people. Each individually will help for all of our work to be translated into public policies. And we can see in our private service that this has good results. We see that with many examples. And we have not lost this battle. Thank you. Now Claudio Sachs to finish. Well, he couldn't connect, actually. He sends his, well, and Claudia could not get back. So we'd like to close this delegation now, the introduction of our delegation. And like we said, Irvin and the group, they are working on a network plan, a network of care plan, which encompasses and includes quality assessment, quality control, certification, and registration. And I hope this model, maybe it can even be a model for the rest of the Latin American countries when it's finally ready. Thank you. Thank you, Pablo. Thank you very much, everyone. Now, Carlos. Well, now, next we will see the delegation of Colombia. We have Dr. Catherine. Please introduce yourselves as you come on the screen so we don't forget anything. Go on.
Good morning, everybody. I'm Herman Perez. I am a neurologist, and it's a huge pleasure to introduce each one of my colleagues representing the Colombian Association. And we are organizing a work group here. I am a professor in the National University of Colombia and also a physician. And we are organizing a network on vascular medicine And the goal is to raise awareness of the general population on cerebrovascular diseases. And a few years ago, I organized in a hospital a department that had some difficulty, especially in relation to management, and it was interrupted. So for me, it's an honor to introduce this group of neurologists, young people, almost all of them trained, additionally trained in cerebrovascular disease. So without further ado, we're going to start with Dr. Mantilla from Hospital San Vicente. Go on, please. You can hear me, right? Yes, we can hear you. What happened to Dr. Mantilla? Well, anyway, now I introduce Dr. Hernan Bayona from Santa Fe, Bogota. Dr. is muted. Okay. Good afternoon, all. Sheila, huge effort. Congratulations. It's a pleasure to see everybody here. It's like a dream coming true. There were a few months when I asked Sheila when we were going to have this, and we talked about the importance of certification for the centers that will improve quality of care for our patients. So as vascular neurologists, it's a pleasure to be involved in this. We're going to improve quality of life for our patients. Our patients will be happy, the families will be happy, and we'll be happy. So I want to give Sheila a clap of hands, and we'll be working together. Thank you, Erna. Now, Romero, I think he was in his office, but I hope he can connect. Okay, Camilo is not with us, so Tony Alvarez. I think Tony's also with a patient. I know it's not a good time for you in Bogota. So, Dr. Pavan. Okay, I'm part of the Colombian team that could not connect. Hi, Sheila, how are you? Professor Bayon, Dr. Perez. I also want to thank you all. A huge work we have ahead of us. And I believe that we are gathered here because we are passionate for neurovascular surgery and stroke. And so I believe that we are strokeologists because we are really passionate about this disease. And we work in a few institutions in Medellin, some private, some public, with the motivation, the energy, and wanting to learn everything you have already done. Sheila, follow your steps. You were an excellent example in Latin America. And we want to adopt all the policies that we will be learning during the symposium. We'll be working together, and an initiative like this will bring together the talent of neurologists and the best knowledge of neuroradiology and etc. And as Dr. Bayona said, the patients will gain, will provide better care, and as Professor Bayona said, it's a dream coming true to be able to work together. And I hope that everybody who's here in the Colombian delegation are able to connect and give their opinion. Thank you all for everything, and I'm very proud to be part of it. Thank you, Pabon. Now, Angel Corredor. Let's see if we are lucky enough to have him here. Yes, thank you. I had I had to stop on the road in order to connect. Thank you, Sheila. Thank you, everybody from Colombia, for the opportunity of being in this committee, national committee. I'm a neurologist in Armenia City. You can see the landscape here. It's great initiative, this. We had no center doing thrombolysis in my city. Now for the last 3 years, step by step, we have been improving care. And now this year I had the opportunity of also engaging a second private center where we started the work of creating a protocol for stroke and increased coverage for patients. So all this work to represent Latin America with an image that's better for our patients, to allow a better approach for the patients. And I believe that all this for Latin America will be very enriching. Thank you again for the opportunity. And we're really willing to get involved with the best intention possible. Looking to do a better work for our patients. Thank you, Angel. Dr. Jorge Mutis from the Childhood Foundation in Bogota. Good morning, everybody. Thank you. Thank you, Dr. Perez, for being the delegate and for introducing ourselves, for inviting us. I also want to personally thank, I'm sorry, his sound is not good. Well, we have some sound problem. What he has been doing is so important for us. Can you hear me? I'm clinical neurologist. I work in the Cardio Childhood Foundation, Bogota. It's for neurovascular and heart diseases. First of all, I want to thank again the whole Colombian Committee of Vascular Diseases to have invited me. For us, it's an honor to participate in this important initiative. Thank you so much. We are attentive to be part on this important mobilization. Thank you, Dr. Mutis. Now, Dr. Lara. Good morning. Can you hear me? My name is Osvaldo Lara. I am a neurologist. I work in Barranquilla in Colombia. Thank you heartily for having invited me to this meeting. I work in Clínica de la Costa, and we had to walk a long way to improve the indicators in our city since I arrived, because there was no thrombolysis. And we assembled a thrombolysis service. We also did not do thrombectomy, now we do. And the care of stroke patients, more than everything, the patients were adrift. So we have started now a process of really organizing step by step the service. Although we have scarce resources, but we're doing everything in our hands to improve care. And we believe that certification process will accelerate that to take us to a point where we have to be and where patients deserve that we are. So thank you so much for the invitation. Thank you, Osvaldo. And now our head, but before of anything, I want to thank Sheila for all this huge effort, all the energy that she put on each initiative, and Carlos and everybody who has been present in this meeting. Now, Dr. Ramaya from Cali. I thank everybody. It's always a pleasure to share with this group that Sheila and Dr. Gerardo, Dr. Perez have organized. We want to be present. We want to work together. We know it's huge effort, but we will be able to improve healthcare for our patients. In my hospital, we have a trend. We're bringing neurologists, radiologists, and currently in Colombia, we have quite a few centers, 50 centers that could be classified as stroke centers and 55 that do thrombectomy. And possibly we want with the certificates that these thrombectomy centers are also holistic centers for stroke and will improve the patient care. In some intensive care centers, we do not have stroke centers, and that will improve us, the care we provide to our centers, to our patients, I'm sorry. 72% of the thrombectomy centers are in 5 cities. In most cities, there is no thrombectomy, no thrombolysis. And this joint effort will help us to achieve that. Thank you all. And now, Mantilla, who is an interventionist, neurologist, and she was able to connect, and she will close our participation. Thank you. As Pablo said, I'm a neurovascular surgeon, and I work with the intention of improving the criteria of patient intervention for acute stroke. And we are very happy with the invitation. So thank you all. I thank the committee, and let us work together. Thank you. Perfect. Thank you. Wonderful participation. We count on you on this huge effort. And now I would like to call my friends from Costa Rica. I see Miguel Barbosa has his camera open. Miguel, please.
Is there anybody else from Costa Rica logged on? Miguel was, yes, but don't know what happened. So maybe we can follow with Ecuador. Let's see. Okay, yeah, sorry, I was on mute. Dr. Luis Mario Piedra will introduce us all, and then I speak in the end. Good morning, good afternoon to some of you. My name is Luis Mario Piedra. I am a neurologist, trained in Colombia, in Bogota, Colombia. I studied at the National Institute of Neurology in Mexico City. It is a great honor and pleasure to participate in this initiative of Sheila and others to join with our experience and academic training that we each had in our own countries. And we can also exchange realities of our own communities. We have 17 million people in our country. It's a very diverse country. We have a social accountability to follow paths that your countries have been following already in our our community of professionals in the cerebrovascular area. I'd like to begin by introducing Dr. Patricio Vat, neurologist. I'm not sure if Dr. Patricio is connected. Dr. Heredia is the president of the Ecuadorian Society of Neurology. And he just excused himself because he had an emergency. All right. Dr. Herman. I'm not sure if he's here. Herman is here. He's one of the first neurointerventionists in the country, and he's raised the flag of thrombectomy. So he is very much involved in thrombectomy and in the stroke topic. Okay, let us talk to the president of the Ecuadorian Society of Neurology. Good afternoon, I am Herman Abdo. And I was speaking with Juan Carlos, but he was with me, but then he had to leave. That's why it took me a while. In any case, I greet you all. It's a great pleasure for me to be here in a meeting with you. And of course, this initiative should be a Latin American meeting, and I congratulate you for having for carrying this meeting, conducting this meeting. Ernesto Maldonado, Nelson Maldonado, we've been together for a while now, and we discuss a lot these topics, and this, which would be one of the best one of the needs of our country to develop this stroke area. And so we were going to talk, well, let us continue with the vascular doctor from Guayaquil. She has to turn on her microphone. Dr. Ignaci is neurointerventionist. He works in Guayaquil. In Ecuador, we're less than a handful, so we are always busy 24/7. One of us is always at an emergency at some hospital because we cover more than one hospital each. Dr. Tatiana Aldaz, perhaps? My name is Tatiana Aldaz. It's a great pleasure to be part of this initiative. I'm glad to be connecting with Latin America as a whole. I graduated from the National University of Colombia, and Dr. Juan Perez was a professor when I was a first-year resident. I am a neurologist now at 2 hospitals. I have subspecialized in Parkinson's disease, and in Ecuador, as Nelson was saying, we are very few doctors, very few neurologists. So as neurologists, we are general neurologists before we are specialized in anything. So we could not but join such a good initiatives as these stroke initiatives. I work in Quito, and I am from a small town 2 hours away from Quito. So I'd like to bring this type of stroke treatment to the smaller towns as well. Thank you, Tatiana. Now, Daniela Di Capo. Hello, good afternoon. My name is Daniela Di Capua. I work at one of the largest public hospitals in the country. Currently, we probably have one of the few, if not the only one stroke unit in Ecuador. We've been working in it for 5 years. At first, it was very difficult to start this unit, and currently our main challenges are to replicate the intravenous fibrinolysis 24/7, which we have in our hospital. We have all the imaging tests like CT and MRI, and we do thrombolysis, intravenous thrombolysis. We want to share all the reports we have because it's very hard to share and collect data. So we also want to start doing mechanical thrombectomy. Neurointerventionism is not a service that we have available 24/7, nor do we have enough resources to have these retrievers. So these are the main challenges that we have as a hospital and as a country, evidently, to replicate that which we've been able to do in these 5 years in the rest, in the other hospitals all over our country. Thank you, Daniela. I'm not sure if Dr. Pais is here. Good afternoon, and congratulations to the organizers. I am Diego Paez. I am a neuroradiologist and interventionist doctor, and I had the opportunity of graduating in a condition in which the stroke unit was important. Well, in our countries, we must, and it's our obligation to implement such a protocol that can be replicated in all countries. And if we don't join neurologists, neuroradiologists, interventionists, we need to have it's an ant work. Little by little, we will plant the seeds and we will reach our main goal. Thank you, Dr. Laura, the neurosurgeon, and Dr. Enrico Bologna, who's an interventionist. They are also part of the stroke team. We'd like to introduce Dr. Nelson Maldonado. neurointensivist who works in the stroke unit in our country. Hello, Luis Mario and my colleagues. I am Nelson Maldonado. I'm a neurologist and neurointensivist. I was trained in the US and then I came back to my city in 2015. First of all, I'd like to thank Shayla for the initiative, and what you are achieving in Brazil can be applied to all Latin American countries. Well, some of us are not so well organized, but we are responsible for improving stroke management all over Latin America. So we thank you for this push and for the opportunity to work. And it's a very difficult and hard work. In Ecuador, well, we are a bit different from all the other countries presented here. Stroke is the fourth cause of death. Second and third are hypertension and diabetes. But we can well remember the data. Certainly, well, if we could collect the real data, stroke would have more, the numbers would be higher. Sometimes we have to plan a protocol to try to be implemented by the government. In the first meeting in Gramado, the only ones that were not politically present was Ecuador, because the minister didn't go, and then nobody was interested, actually, because obviously this is not one of their priorities. So they don't know about this disease called stroke. As to medications in our country, up to 2019, we had to struggle to get the medications in our public hospitals. And if we can, well, from 2016, we started to have the basic medications in this, but only in this main hospital. We count on one unit in the country, stroke unit, and it is located at a public hospital. And there is no interest by private hospitals to have a stroke unit, and they could afford to have them. As to thrombectomy, we don't do them we only do them in private hospitals, not public hospitals, because we don't have stains. We don't have, many times we don't have a CT machine. We don't even have a residency in neurology in our country. So the only neurologists are trained abroad, and most of them, well, basically, most of them work in more than one hospital. So we go from one hospital to another. And if we don't have this residency, we cannot have a subspecialty, which is vascular neurology. So, however, for the first time, we have a group of specialists. And what's interesting is that when they come back from their training, they go either to Quito or Guayaquil, and then they go to Mexico also to be trained. And we are about 10, 12 doctors, and we all have the same willingness to work. In 2019, we started working with the Angels Initiative, and Thomas Fisher was really an angel to us. We went from 20 to 300 patients. Obviously, it's not so much, but for a start, it's quite important. We use tools like WhatsApp, neurologists, and So I believe that with this initiative, well, we need our government to invest resources in this field and to improve the treatment and management of stroke. So this is a little bit about our country, and I thank you very much for what you are doing, and I greet all my colleagues.
Excellent. Thank you, Nelson. Certainly, we'll be able to improve. I would like to know if Miguel was able to connect from Costa Rica. Miguel? Okay, great. So, Costa Rica. Well, my connection is a bit unstable. Thank you for the opportunity. I'm a neurovascular surgeon in Costa Rica, and I represent all the colleagues who could not participate. We're a little bit busy today. Nevertheless, on behalf of the head of the Department of Neurology in our hospital, and also Dr. Monica Carlo, I would like to thank you for this invitation. And Dr. Ricardo Rincon, I'm sorry, his sound is breaking so much, I cannot understand him. Organizing the unit and the stroke unit in the hospital where I work. We've been working to organize better the department. We also serve the public sector, and we do thrombolysis and thrombectomy in the public sector, and in the whole region we've been working so that even the small towns have medication and access to care. And we want to spread or disseminate what we've been doing in the public sector. And we want to offer quality care as Dr. Martha is organizing, and we can demonstrate that we have the capacity of, sorry, he's breaking. With so many mountains they have there. Yes, okay, okay. I don't know how much you heard. Well, thank you. And once again, I want to thank you for the opportunity. And I have much connection problem. We would like to invite all the 5 units to participate here. Now we're going to Mexican delegation, Carlos. Thank you, Sheila. We'll see the scenario we have in Mexico. Now I'm going to ask Dr. Góngora, former president of the Mexican Society on Stroke, Ibero-American Society. It's a very active person, and Mexico has good quality health. So, Dr. Góngora, I thank you for the invitation. Thank you, Sheila. And once again, we are here to support you. For us, it's been a huge pleasure to follow your initiatives. And I believe with your leadership, and now Dr. Gerardo we will really have huge support in Latin America. The considerations are in tune because we have now a professor, Dr. Carlos Cantu, so we're very happy for that. And the platform of work is very well aligned. As Carlos has commented, the Mexican society is old already. We've been fighting to have stroke as a priority in our country. The initiatives since Dr. Varinaga, the first president, and Dr. Cantu, etc., many people has participated. And maybe we put a grain of sand to really build this beach. And we have political changes now that also have to do with health besides the pandemic. We are advancing a bit though, and we have achieved some development, and the association has recognized or accredited maybe 23 centers. Some of those centers can do thrombectomy. And I'm very happy to be here with you, especially to see so many friendly faces. We have worked hand in hand for many years. And now that I'm here, I'm part of this working troop. And I'll be working with you. So I want to really say hello to all of you. And here we are. Thank you, Fernando. Now, Dr. Yeham from the Stroke Organization and the Mexican Society, Cerebrovascular Society, and he's part of the steering board. Hi there. Thank you for the invitation. I'm Juan Caleja. I'm the head of urgencies in neurology in Mexico and vice president of the Mexican Society. And just want to paint in yellow that in Mexico, we're putting much effort, individual efforts, and also group efforts. We have certified services. We have some that are not certified, and we have an idea of what we have to have in terms of certification. But for sure, it seems important for us, and we're happy to be coordinated with this huge effort that Sheila is making to unify, to coordinate, to disseminate this effort in Latin America. And it's great to see here friends, people that we have known for a long time, and also get to know people whose name we knew. So I'm very glad, and I want to congratulate you for this huge effort of bringing us together here for this initiative. I'm sure it's going to be great for everybody. We're very happy to participate. Thank you, Juan. Also a message from Carlos Espinosa. He has been in many steering boards and worked a lot for this organization. Are you there, Carlos Espinosa? Hello, how are you? Well, it's an honor to be here with you. It's a titanic initiative. I'm very glad to be with you. Sheila Martins and Dr. Carlos Carto, thank you for the invitation. I work in a state center called in Tolucas, that is about 60 kilometers from Mexico City. And we have had circumstances, adverse circumstances, to make more accessible the neurovascular treatment. But we are advancing more and more. We're very much ahead than when we started, and we're more and more happy to achieve more things. So we are together with you in this initiative. What is not standardized cannot be improved. So this Pan-American initiative, along with all the sister countries of harmonizing measurements, is fantastic. So you can count on us. Thank you. One of the last delegates we have here is also one of the most important persons, young persons, because he's in a center, Institute of Medical Sciences. He's professor in charge of training vascular neurologists in Mexico, Central America, Guatemala, Nicaragua, Honduras. So I asked Dr. Fernando Flores to say a few words on what he does and what's being done in the Institute. Hello, everybody. Thank you, Carlos. My name is Fernando Flores. I represent the National Institute. We train people in neurovascular diseases, improving the healthcare for stroke patients. I believe that the centers where we train neurologists and vascular neurologists, we have a responsibility in the sense of training the medical professionals and also trying to always improve and standardize centers in patient care for those patients with brain neurovascular disease. And I'm very glad to see all these professors here bringing together individual efforts. And I'm really moved to think about what we can do together and count on us. We all can improve always. We never do it perfectly. And in this sense, we are very, very happy to cooperate with the sister countries. And I want to acknowledge the leadership of Dr. Martins in the sense that we are all connected here. We're part of this effort. We recognize that, and we are working with the same, in the same tune. As Dr. Carlos said, you can really count on us. Thank you. Now, final message from Mexico. Mexico is a complex country. You know that it has some political problems, huge poverty, 60 million poor people who do not have access to a stroke center, mortality 50% in hemorrhagic stroke, 20% in infarction. And I have been an epidemiologist in stroke, and this numbers are from last year. So this initiative is so important, and it will be organized so that we can improve this problem in the country. Now I want to call Panama. No, so I have not seen him. I have not seen him. Oh, I didn't see Nelson. I don't think they are connected. So Sheila. So I'd like to call Paraguay, who are connected. Ricardo, Alan, Donovan, hello. Welcome. So we're going to introduce Paraguay's delegation. Would you like, well, Donovan is going to be first and then I go. Good afternoon, everybody. It's a pleasure to be here with neurovascular neurology. I am Donovan Oresco, neurologist. I am the head of the Central Hospital, which is a hospital that takes care of workers. It's 19% of Paraguay's population that is served there. And I'm also the coordinator of the stroke unit in Rioberto Cavaleiro Center in Paraguay, which is and this sector works with the workers and does not correspond to the whole of the country, but it's an important population. Dr. Ricardo will be talking about the populational aspects. And we have a joint work. Currently, the units that we have, especially the ones that are in capital, in Asunción, we have a project of teleictus, telestroke from other centers, and also some projects. The central hospital, we do endovenous thrombolysis. We have developed that, and we want to start thrombectomy, and for that, we have a physician there who is in our group. Nevertheless, she had to leave because of work aspects, and she's in Barcelona being trained, and she will be back to our unit. So we are able to go forward. Nevertheless, we have many difficulties still. And I believe that we have a lot to thank Sheila and the team of the Cerebrovascular Society for organizing this opportunity of us being able to go on. We have been struggling for 8 years. Nevertheless, we still are not where we want to be. And we want to follow the steps and collect data and adjust according to international basis. We also have in our team Dr. Gloria Mesa, who currently is not connected. Nevertheless, she was one of the pushers for the connection with the Ibero-American team. And also another colleague who is a consultant in what would be the central, the core, and Dr. Fatima Pedroso, who is now in the team. So she will also say a few words. And now I give the floor to somebody else. Okay, can you hear me? I think Dr. Luis is here. Can he say anything? Luis, are you there? Okay, it's great to be here with you. I'm so glad to be part of this initiative. As it was said, the strength of this of all these people, we're following the steps of our professors who provided us with the tools to do all this. And it's great to cooperate, to do everything necessary. I work in the clinics hospital, university hospital, in the School of Medicine, and also work in the university since 2016, organizing the data system, organizing the database. And as I said, it's a huge pleasure to be here with all of you. Thank you, Luis. Now I give the floor to Fatima. Can you say anything? Hi, everybody. I am Fatima Pedroso, specialist in neurology, and I work in the clinics hospital and also in the university. And for me, it's an honor to be part of this team. And we want to improve the care for our patients. Thank you, Fatima. Now, André Silva, he's a nurse specialized in management of stroke wards. Are you there? Yes, I'm here. Good afternoon. Thank you for the invitation.
My name is Andrés Silva. I'm a specialist in emergency. I work at the clinical hospital. We know that the nursing department is having a quite important role. Thank you, Andres. Is anybody else from Paraguay online, please? Okay, so I will speak. I'm Ricardo Mernes. Do you hear me? Yes. I'm Ricardo Mernes. I'm a vascular neurologist. I also work in interventionism. I work in the stroke unit at the clinical hospital. And we have 3 units. 2 have been consolidated. 1 belongs to the central hospital. It's been there since 2012, and we've been at the Clínicas Hospital since 2015. So we started in 2015 with Dr. Alan Flores was the head at that time. And 2016 was an important year for us because we managed to have an extra hospital stroke protocol with the ambulance people from Paraguay. And the system brings together all of the public hospitals in the metropolitan area. And we have a permanent communication with these units. We wanted to improve our quality because we were having a greater number of patients treated, and we wanted to improve our quality parameters, time to CT and things like that. So we published that in many in journals. So we had a lot of communication with the people from the Ministry of Health, Douglas Roy, who was a representative there, and we are now talking to him to improve our scenario for stroke treatment in Brazil, especially with the telestroke system. It's one goal that we have for 2021. And the second goal would be to have mechanical thrombectomy. This is a 3rd level hospital center, and we would have access to neurosurgery, intensive care, and also mechanical thrombectomy if necessary. The only limiting factor is the price of the materials, especially for us at the Clínicas Hospital for mechanical thrombectomy. And I am the only interventionist there, so it's difficult to have that 24/7. This is similar to the central hospital as well. Well, we are in the right path. We slowly but surely, we realize we are moving forward. Our situation is much different than what we had a few years ago. And we believe that if we move on ahead, the second step, the next step will be certification, and we'll systematize our service as well. So the initiative is very important. You are leading, Shayla, you are leading the continent, and we will make a point of following you. Thank you very much. Well, let us now hear the last delegation, and then we have Ana Valencia, we have Carlos Avanto, and who would be the other one? Who will begin? Just 1 minute before we finish, we want a picture with all of us on the screen, so please don't leave. Carlos, you may begin. We have Dr. Miguel Quiñones. Well, this is a beautiful opportunity for us to gather here with our colleagues. We had our last course in Brazil, and on the last day, we were very touched when the activities were closed. And well, in Peru, Dr. Ana Valencia will introduce herself and the rest of the delegation. Anita, good afternoon, everyone. Good afternoon, Shayla. We are very thankful for this initiative, and it's a long way to follow to make our dreams become a reality. We at the Institute, I am the chief of the vascular neurology department, and we've been dealing for 10 years with stroke. But after a long time, we managed to consolidate a stroke unit, but many times we did not have enough support from the state, and in the conditions that we work, well, this year, in face of all of the pandemics, and we actually managed to contact everyone, the Ministry of Health, and on the 29th of October, finally, we will begin and celebrate the opening of this telestroke unit. It's a joint effort of all the people in the hospital, and to us, this is very important. We can see that we are taking a step forward, and what we really want is to call attention from the Ministry of Health. Thank you so much, Shayla, for this initiative. Thank you, everyone, our colleagues, because all of those working on this, and that's why we are here, right? To work together. Thanks. Dr. Miguel Quiñones. First, I'd like to say good afternoon, everyone. Shayla, I am enchanted. It's a spectacular work that Dr. Carlos Cantur also. It's a very interesting, all this work that we are doing. I am introducing myself. I'm Dr. Miguel Quiñones. I am a vascular neurologist. I'm currently the president of the Stroke Group of Peru. And this is an association that's been around for 17 years. No, I'm sorry, 13 years. And it brings together all neurologists who have some affinity with stroke, interventionists, radiologists, emergency doctors, cardiologists, and hematologists even. This is an association that is very broad and important, and it was created because of an interest, because of the interest to speak about this disease, stroke, in our country. And we have been traveling the country trying to meet colleagues and the public in general, and instructing people about the importance of this disease, because many times patients can be recovered. So we began to talk to a lot of people, and currently there are many places in Peru where they do thrombolysis. problem is that in many countries, there are not enough doctors, there are not enough neurologists. And in Peru, up until now, there are regions where there isn't even one general neurologist, just to give you an idea. So to do vascular treatment in everyone, it's complicated. So for those, well, in the at places where we have been working, and we have some centers where they do thrombolysis in the best way possible. I also work in the Guillermo Almenara Hospital, and in this hospital, we say we did the first thrombolysis in Peru 16, 17 years ago in 2013. And since then, with the interest of Carlos and Anita, I'd like to say that, well, this is what we are facing now. I believe that these actions are very valuable. And I think if we work with our heart, it will to work out well. And we can have this option, and we can add that, we can give this option to all those who have that same condition.
And our patients are workers, or they work formally, I mean, and they represent almost 30% in the country. We are around 11 million people. And we count on a vascular protocol that really helps us. And we now are taking forward many activities. We have trained all the members in emergency care so that they know the diseases, and the nurses and the techniques on what to do with the patients, etc. And we still have to do some external work. Internally, we have done well. We do thrombolysis, and it's something that's not extraordinary there. We do it oftentimes. And this experience also was taken for other hospitals that got enthusiastic. I thank you for this opportunity. I am really happy because this is something we need. We need that in our region. And this is something that I hope that we all will be able to make true. It will be an effort for everybody, but that's what we're here for. Thank you all, above all, Sheila and Dr. Carlos Cantu, for all this. My name is Carlos Abanto. I am the president of the Peruvian Society of Neurology, and I would like to comment that Peru is a country where oftentimes we have a difficulty in access. In Peru, stroke is the second cause of death, and nobody certifies stroke units. So this is a beautiful opportunity. And what we're doing now will improve that. In Peru, we have also done a study. There is a publication that we see what we can do in quality of care. We are around 50%. We have to do a lot. It's a beautiful opportunity, and we'll try to reach 25%. And the health system is different. We have the public, or the Ministry of Health, where we work. We have social insurance, and also we have the militaries and a private system. Initially, we got together and we are friends, and that allows us to work better. We will put together other groups with younger people tending to endovascular medicine that are being prepared. And we are going to reach the Ministry of Health, where we intend to have the Prevention and Control National Program for Strokes. And we have representatives all over, not just Lima. We are more than 30 million inhabitants, and 1/3 is in Lima. But we want to reach all over Peru. We want to thank Carlos, Sheila, all of you, because I believe we have started well as team, and that's the cornerstone to go on improving. Thank you. Anybody else from Peru? No? I think Carlos was the last one. So before we finish, I would like you all to open your cameras so that we make a picture of the whole group. So open your cameras. Okay. We want to have a diagnosis in 2 to 8 weeks. Okay, everybody with their camera open. Lucas, can you take only one picture? Can you put everybody in one single screen? Okay, Lucas. We are finishing. Smile, say cheese. As he takes the last pictures, I would like to thank Hartley, say that I'm so moved with your participation, and everybody got organized, very quickly organized their committees. We have 10 countries here, almost 70 people from the delegations, and more than 400 people watching us. So this is a sign that's going to be very good. Everybody's going to work, and we'll be implementing this in the next month, starting to applications for the centers. Everybody next week, the stroke day, everybody will be together. I'm going to send an email and I invite everybody to participate on the World Campaign on Stroke in the coming week. Thank you all. Thank you. Bye-bye.